All right. It is 6:30. And the surgeon in me always likes to be prompt. So I'll start with some introductions as people trickle in and some welcome. So first of all, good evening, everybody. My name is Hans Aurora. I have really the pleasure to be your president of the Durham-Orange County Medical Society for the 2025 year. I'm very excited because we are trying to tread into some unprecedented waters for the medical society. As many of you know, our medical society has had certain struggles over recent years, particularly since COVID. And so, after many discussions with the board over the past year and a half, we said, well, how can we adapt this changing environment, and where are the things that we can flex on, and how can we grow as a result of it? And so one of the decisions we made is to switch, instead of doing all in-person meetings, to do some virtual meetings. But the upside of being able to do something like that is that we have the opportunity to broaden our reach of speakers. Just like tonight, where we have a dear friend of mine, Dr. Andrew Rudawsky, with us to talk a little bit about informatics and AI. So I would like to acknowledge the hard work of our board as well, who are on with us, and then for tonight, specifically for Nate Erskine, who is our inaugural program chair, something we've talked about for years, but something we have just recently implemented, where Nate is working hard to organize speakers as we start thinking about other ways we can branch out and serve our membership and attract new members. Um, with that, I'll give it a little introduction for Dr. Wodowski and then pass it off to him. I think he has some slides to share with us, and then we'll have an opportunity for Q&A. I'm actually going to defer to to Nate Erskine to be able to moderate that Q&A. I think it would be great for him as our program chair to be able to do that. If there are no questions, I want to introduce Dr. Andrew Rudowsky, or Rudy, as his friends call him. He's an emergency medicine physician at Cleveland Clinic. So instead of being here in Ohio, he's actually here in North Carolina. He's actually in Ohio, born and raised, and did all his training in Ohio. One of his really interesting roles, besides being an emergency medicine physician, is actually being the associate medical director of informatics for emergency services, the Cleveland Clinic term for the emergency department, where he works on optimizing things like the electronic health record. They use Epic up there, improving clinical workflows and integrating emerging technologies into patient care. As in addition to his technology informatics side, Rudy's actually very involved in health policy and advocacy. It's actually how the two of us know each other. He's been engaged in the American Medical Association since being a first-year medical student, which, Rudy, that feels like a long time ago for both of us at this point. And he actually serves as vice chair of the Ohio delegation to the AMA, where he advocates for a broad list of policy improvements. With that, I am really excited to turn the attention over to Rudy. Rudy, thank you for being here.
Oh yeah, thank you guys for having me. This is an exciting opportunity, and I have a limited circle in which I can talk about informatics. I think everybody around me is sick of hearing about it. So to to talk about it to a new audience is always pretty exciting. So thanks for having me. Let me just pull up my slides here. All right, are you guys able to see that? Wonderful. So I'd like to talk about a few things. One, I want to talk about informatics in general, and then AI is certainly a hot topic these days. So I wanted to delve into that a little bit as well, with some words of caution about using this technology, which is still in its infancy. Disclosures, I'm going to talk about a few different products today. I'm not endorsing any of these in particular. I have no financial interests in any of these companies that I mentioned. And these views are my own. They don't necessarily represent the views of the Cleveland Clinic. So about me, like Hans had said, I'm an emergency physician at the Cleveland Clinic. I've been there about 8 years now. I'm also the Associate Medical Director of Informatics. So we have about 29 emergency departments across Ohio and Florida. And that role is keeping me increasingly busy. My areas of interest are optimizing the electronic medical record. We use Epic, improving our clinical workflows, and then integrating some of these emerging technologies to try to reduce physician workload and help with burnout. So what is clinical informatics? This is a definition that ChatGPT gave me, actually. It's the intersection of healthcare, data science, and technology to improve patient care, streamline workflows, and support clinical decision-making. A lot of you guys are probably involved in informatics without even realizing it. And something as simple as setting up, a dot phrase or a preference list or an order set could be considered informatics. So you probably have more experience with it than you realize. My goals of informatics at the Cleveland Clinic are to identify situations in which we could use computers of the electronic medical record to influence outcomes. We could either look for highly audited or high-risk situations, or situations that we encounter every single day. And the examples I'm going to give of my informatics work are really to shed light in these either high risk or high frequency events. We also do a lot of care paths. So across 29 emergency departments and a few states, we have a lot of variability in terms of provider preferences and training and regional practices. So it can be hard to standardize care across an entire enterprise. We've done that by developing care paths or guardrails, and we have, I think, 40 of these medical conditions now, AFib, ectopic pregnancy, stroke, chest pain, things like that, that we have to get right every single time. And we do that by developing care paths. And then finally, we work to reduce physician workload by automating some of the things that we have to do over and over and over again. If we make it easy to do the right thing, if we have the computer do this for you every time, physicians are going to be a little bit happier. So like I mentioned, these examples that I'm going to show you, I don't think are necessarily the most interesting or the most groundbreaking, but hopefully they're examples of things that we all encounter in our clinical practices that we can use Epic or the medical record in general to automate or make more reliable. First is something that I think we probably all encounter extremely frequently. It's chest pain. Chest pain is 5 to 10% of all emergency department visits annually across the nation. That's about 10 million visits for chest pain per year. And I think that makes sense. I mean, the heart's important, I've heard, and people want to take it seriously. So when they have chest pain, it's a really good reason to come to the ED. And because we encounter this so frequently, we wanted to standardize care of this and reduce some of the cognitive burden. So if I'm always going to order the same laboratory tests or always order an EKG, is there an opportunity to automate that? The Mercy and Duke healthcare systems collaborated back in 2019 to develop a reflex troponin test within the laboratory module of Beaker. And I was able to see that presentation. It was really exciting stuff. Nobody had thought about kind of automating some of those labs that we order very frequently. And they came up with a really creative solution. So we took that back to my institution and tried to implement something similar. So credit where credit's due. Thank you, Duke, for doing such a great job on that project. We developed a care path where we looked at everybody that came to the emergency department for lower moderate risk chest pain. Now, of course, if this was a clear STEMI, you'd be off of this pathway. If we had no suspicion for a cardiac cause of your chest pain, you'd be off of the pathway. But for the majority of patients that came in with chest pain, they fall into this lower moderate risk group. And we can use laboratory testing only to risk stratify them. Using that Duke model, we had created some ordering logic where we placed this single order for a high sensitivity troponin. And depending on the results of this test, the computer itself will order subsequent tests, either one additional test, two additional tests, and automate the timing of those tests. What was happening to me in residency at a different location that didn't have this, we would get the troponin, and I would forget, you get busy on your shift, and you would forget to draw this thing 3 hours later when it was appropriate, and then, the test got delayed. Or conversely, you put in the order, you ask the nurse, hey, please wait to draw this, and it gets drawn early, and you have to end up drawing another one anyways. So this uses the EMR to completely automate this process. It then takes this information and automatically puts it into our documentation. So this will pop up in a very consistent area in the note. It has a nice little flow chart that I'll show you an example of, where you can see where you are in the pathway. And it ensures that people that might be using some other methods, like the heart score, for example, or a previous generation troponin or some other way to risk stratify, can easily use this. We make it easy to do the right thing, and then even do the documentation for you. So here's our care path. Start up here, order the troponin test. Like I mentioned, if this is a STEMI, of course, you're off the pathway. Depending on the results, this will automatically move through the care path, order the correct number of tests, and then recommend a disposition. So as an example, this is a patient that had an indeterminate troponin, so in between 12 and 51. It ordered the appropriate follow-up test. It ordered a third 3-hour test. The change in the troponin was less than a predetermined value. And it recommended that MI was ruled out, and the patient was very low risk. Their risk of MI using this care path is 0.4%. Then we went and we validated this care path. So we looked at all of our cases of chest pain across the enterprise in 2022. We found retrospectively that a lot of those admissions were not productive. We used to admit a lot of these patients to the hospital. They might get a stress test. Almost always the stress test was negative. And we ended up sending those patients home with a pretty hefty hospital bill. So using this new system, we were able to decrease our avoidable admissions to less than 1%. So a 25% decrease, or a couple thousand patients per year we could send home across the enterprise that we couldn't previously. Another area that we tried to standardize care using the electronic medical record was this medical decision-making. So in emergency medicine, we don't use the traditional SOAP note format. We do have a subjective and an objective, but the assessment and plan are kind of combined into an area called medical decision-making. And that's because we have multiple touch points during the ED encounter. So I might see the patient initially, say, I think your chest pain could be a PE or ACS or maybe a pneumothorax. So we would order tests, we would go and check on the patient, see if their chest pain had improved after aspirin and nitroglycerin, and then as tests come back, we further refine our differential diagnoses. So there was this generational change, in 2023 that basically we would build the entire visit only based on our documentation in the medical decision-making section. So HPI was thrown out, review of systems was thrown out, physical exam was even thrown out. This is, really where the important documentation happened. So we wanted to make it easy for people to document the right things. And we did this by scouring the medical record, the orders, and looking for dynamic events. So if you consult somebody, highlight that there was a consult place, or highlight that the patient was going to be admitted, and document that important conversation with the admitting team. We found that through our billing and coding team, documentation of review of past medical records was really important. So if we notice that you go into the charting review tab, you're looking at historical records, highlight that. For certain high-risk conditions like chest pain, syncope, headache, back pain, altered mental status, we have a number of them. Help us generate a list of differential diagnoses. For some things, that's pretty obvious even to a first-year med student. But for other conditions that we encounter less frequently, these lists of differential diagnoses can be really helpful. We collaborated with otolaryngology, with ophthalmology to generate specialty-specific differential diagnoses for certain conditions. So if we have a patient that comes in with eye pain, our ophthalmology colleagues have provided us with a list of rule in and rule out criteria. And then finally, take all of these little buttons that we can click and generate this in a note that's actually readable to people in prose format. Another area that we have invested a lot of time and resources in is standardizing very highly audited or regulated processes. An example of this is something called the Baker Act. This is Florida's involuntary admission for mental health disorders process. So if you have a patient that comes in with severe depression, complaining of suicidal ideation, the Baker Act is the law that surrounds how we would involuntarily admit that patient to the hospital. There are so many different rules and regulations, appropriately so, surrounding how this is done. The form has to be filled out in a very specific way, in a certain order. It has to be done when the patient first is evaluated. It's not something that can be delayed. And we found, looking at the previous process at our Florida hospitals, that we were lacking. The forms weren't always filled out completely. They weren't filled out by the right individuals. They weren't filled out in the correct time in the process. And when that's on paper, we really have very little ability to enforce that. So we reproduced the entire Florida form electronically in a medical record. And by doing that, we ensured that every single step was completed properly. We actually achieved 100% compliance in an audit that was done earlier this year. So this is just an example of what that looks like. We reproduced the form. Our legal team was able to supply us with appropriate language to be used in all of these statements. And after filling this out electronically, it actually populates the exact form that Florida uses. And if this form ever changes in formatting, our work in the electronic medical record doesn't have to change. We just update how it's typed into the form. So it's very easy to maintain as well. The other nice thing about having this all done electronically is we can then capture this information and use it to automate other processes. So we can display trackboard icons when a patient has had a Baker Act form completed, and meaning they are not allowed to leave the emergency department or the hospital. We can add countdown timers because we can only keep these patients for a certain amount of time. We can automatically page psychiatry when this has been completed because the timer has started. They have to receive an evaluation by a psychiatrist. We can even ensure that their meal trays are the appropriate safety trays without metal utensils, for example. And then finally, these all have to be submitted to the Florida Department of Children and Families. So that process is now handled automatically. One additional thing that we've been working on in the past year is we've been changing our patient care and triage process. So I'm sure that you guys have experienced the problem of patient boarding in the hospital and the emergency department. Our waiting rooms are increasingly packed to the gills. And because of this, we've been seeing patients in non-traditional environments. There's a lot of waiting room or hallway medicine. It's not unusual to see a patient in a chair or a bed in a hallway as opposed to an emergency department room. So what we've done is we've started putting a physician in our triage area. That helps us get eyes on the patient as soon as they come in the door, so we can identify who is truly sick, who has to be seen, and who can wait. And we can also initiate these workups earlier because I know from being a patient in the ED, it's very frustrating to sit there and wait for hours without anything being done. But if you can have somebody see you as soon as you get in, even if it isn't the provider that ends up taking care of you, I can at least know, okay, my EKG is okay, I have an X-ray in process, my laboratory studies are in process. Patients are a little bit more invested in staying in the ED. They feel like something's being done. So in these physician and triage shifts, when this is being done in person, it's not unusual to see 60 to 80 patients in an 8 to 10 hour shift. It's pretty amazing how quickly the patients can come through. We also have a pretty unique virtual model where for certain smaller emergency departments, like two of the ones that I work at, we don't have the volume to support a full-time physician being always there in triage. So we actually have created a system through the electronic medical record where nurses can page a virtual provider that sits in their home office, and they wear their scrubs and a white coat, and they can dial in on an iPad, they can triage the patient, they can get a brief history, maybe have the nurse assist with a physical exam, and then get things started. And in those shifts, in 8 to 10 hours, they can see 120 to sometimes 150 patients. So as you can imagine, when you're seeing patients that quickly, every single click through the EMR is amplified. If you have 1 or 2 extra clicks, 120 times a day, that really, really adds up. So it's forced us to be very purposeful in how we design these systems and really try to squeeze every single bit of efficiency out of it. So here's an example of some of the tools that we've created for this physician in triage or an internal treatment area process. We have a triage tracking where we can prioritize what patients are truly sick, which ones need to come back urgently, which ones can stay in the waiting room and wait for the results, which might be appropriate for a hall bed or a chair. If patients need IV access, we have at most sites a dedicated either nurse or paramedic that's able to start IVs and draw those laboratory tests. We've also created some tools where providers can very quickly enter a brief triage note to help the physician that eventually sees them. Excuse me. Finally, all of this information is displayed on our ED track board, so we can see at a glance, these are the patients in the waiting room. These are the ones that have results that are ready. All their laboratory and imaging tests are back. So maybe that would be an appropriate patient to bring back and see in the internal waiting area and maybe make a disposition. Are there any questions about current informatics work or any of the things that I've mentioned so far?
We actually did get a couple of questions.
Sure.
So first is from Hans. It says, my impression of emergency care has become much more broadly protocol driven than some other specialties.
Mm-hmm.
For things like surgery or primary care, are there examples of how AI or informatics can be used to improve the care we deliver?
Well, you are absolutely right. Protocols are the name of the game. If we can create a way to very safely risk stratify patients and standardize care, that's the way to go. I know I mentioned our chest pain pathway and reducing inappropriate admissions. That was a tough pill for a lot of our docs to swallow at first. It was a big change from using our clinical judgment and something like a heart score that might more subjectively risk stratify somebody. But by implementing this care path and then validating that care path and showing that when we discharge these patients, there are no adverse outcomes, the risk of MACE at 6 weeks is less than 0.5%. That was really reassuring for people. And it's something that we've been able to reproduce over and over again with pulmonary embolism disposition or AFib disposition. We created a care path 2 or 3 years ago for kind of prioritizing cardioversion for the AFib patient. It wasn't too long ago, I was in residency. We were admitting all of these patients for observation. They'd see cardiology, they'd get cardioverted and have a 2 or 3 day hospital stay. I cardioverted in 2 shifts, 5 patients last week, and they were able to go home, which was a tremendous saving for the patient in terms of time and money. And it was a tremendous saving for the healthcare system because we aren't taking up our precious hospital beds with patients that aren't really going to have a productive admission.
Thanks, Dr. Rudawsky. And then I have one more question. This comes from Robin. She asks, are there tools or services out there to help individual providers in private practice create these tools, such as suicidality, risk stratification to escalate to a higher level of care? And also, I guess, particularly too, for people who may not be using Epic.
Yes, there definitely are. I have a slide or 2 at the very end of this that touches on that, but a lot of the different EMRs, and I'm familiar with Epic, so that's what I'm going to talk about mostly, have pretty active communities. So Epic has something called Epic Galaxy, and there's the Epic user forum, where you can take things that other institutes have programmed and very easily, with your informatics team, import that into your own EMR. So if you have a particular pain point in your practice, if you find yourself doing the same thing over and over again, it would be very worthwhile to go to that user forum of your particular EMR and see if somebody else has encountered the same thing and already has an implemented solution. I mean, that's what we did with the Duke chest pain care path, and it worked out really well for us.
Thank you.
So I wanted to speak a little bit about emerging technologies and artificial intelligence, because that is the new hot, sexy topic in informatics. It seems like everywhere, not only in the hospitals, but in the news, we're constantly being bombarded by this or that AI product. In fact, there were several that were available to help me make this PowerPoint presentation. First, I wanted to define AI. The one we're probably most familiar with would be large language models or generative augmented intelligence. It's a type of AI that can summarize, translate, or generate text or images, videos, even sound bites based on training from extremely large data sets. One of the ones that people are probably most familiar with would be something like OpenAI's ChatGPT. Currently on their, can't keep track of their modeling number. I think they're on 403, something like that. And ChatGPT 5 is supposed to come out this spring. There's also machine learning, and that's a type of AI, but it's really an algorithm that looks at large data sets to try to predict outcomes or model behavior. I wanted to caution everyone that AI is kind of the Wild West at the moment. There are really no governing bodies that will look at AI in general. The US Department of Health and Human Services established an AI office in 2021, and there was a pretty meaningful executive order in 2023 that listed some guidelines for the use of artificial intelligence in general. And this isn't necessarily in healthcare, but just in general. New companies are submitting applications to the FDA for their AI products continuously. In May of 2024, which is the most recent data that I could find, there were 882 different AI products that were approved by the FDA. And almost all of these are related to image analysis for radiology or pathology, but that is trickling into other fields slowly as well. AI is not perfect. It is trained on data, and as we know, all data has some amount of bias. There could be racial or ethnic bias, gender bias, disability bias. And we don't understand clearly how a lot of these models work under the hood. We can give them an output or an input and look at an output. But as we know, the outputs aren't necessarily consistent day to day, week to week, month to month. Even the same models can drift and generate slightly different outputs over time. The data processing or pre-processing before you program your model can be confounded by bias. And then as we develop and train these models, although we may think that we have an excellent algorithm, unfortunately, unless we are looking at an entire population, there can be bias as well. I think one of the most well-known examples was the organ transplant list. There was an algorithm that was used to prioritize people on a renal transplant list. And unfortunately, it was disproportionately disadvantaging African Americans from receiving these kidneys. So it's something that we really have to be aware of. There are a number of institutions that kind of popped up to examine these different AI algorithms. Two of them were actually started by Duke. So there's Kai, which is the kind of original or most well-known AI governing body. They try to publish a list of algorithms that have been evaluated, list the strengths and weaknesses of these different algorithms, and try to help institutions that are going to implement something like this, a list of things to look for and ways to implement this safely. Kai has kind of expanded into something called TRAIN. It's the Trustworthy and Responsible AI Network. Duke was one of the first 5 founding members, but there are now 50 different organizations that are part of this. Cleveland Clinic's one of them. There are also corporations like Microsoft is heavily involved in TRAIN. And as your institutions implement AI, this would be a great place to look for resources. So delving into some specific products, the one that's getting the most attention right now are AI scribes. So this is a technology. Typically, you would bring your cell phone into the exam room or have your office wired with microphones. And it records the conversation back and forth between you and the patient, the family member, and then generates your documentation for you. There are many different variations on this. A couple of companies are doing it particularly well. I have experience personally with Ambient and Abridge and DAX Copilot, but there are plenty of others. I think overall, this is a great technology for your HPI and physical exam. I think some of the medical decision-making information is lacking. And it's also most geared towards the ambulatory setting at the moment. I think inpatient and the emergency department maybe a year or two from now would come along, but these products are really focused on the ambulatory space at the moment. They are very easy to implement. So you don't necessarily have to have this tied into your electronic medical record. In fact, when all 3 of these companies launched, we would have a separate web browser window. You go back to your workstation, it would have your note in the web browser, and you just copy and paste it into your EMR of choice. But some of them have gotten really slick where they're integrated now. You don't even need to do any extra clicking. It just shows up in the patient's chart, which is nice. So more to come on those. It is a pretty worthwhile service. I think it will continue to become more valuable in the next year or 2. There's also open evidence. I really like open evidence. I use this a few times on my shift today. I had a patient that had a testicular torsion that torsed and then detorsed, and I didn't have specific discharge instructions in my EMR about what to do in that situation. I talked to urology. I know the patient had follow-up. So I asked Open Evidence, which is generative EI trained on medical literature, to write some discharge instructions for an emergency department patient with testicular torsion that had detorsed, give them a list of signs and symptoms for us to return to the emergency department, and include information about the specific follow-up appointment for their urologist. And it did it. It was wonderful. It cited its sources. It's also a great way you can ask clinical questions. So my brother-in-law's father was recently diagnosed with signet cell carcinoma of the esophagus, and I'm a ER doc. I don't know a ton about different treatment options or even prognosis for a lot of malignancies. So I asked Open Evidence, what is the prognosis for stage 3 signet cell carcinoma of the distal esophagus? And it was able to give me a great kind of springboard for a more in-depth literature search. Open Evidence is free for any clinician to use. You can create an account and ask you for your institution email, but you don't have to. I think that this is going to be a really exciting technology in the future, but it's something that, even in its current form, is still very useful and anybody can jump in and use. One of the tools we've been tinkering with recently is a sepsis identification tool. So I included this as an example of machine learning. It runs in the background at one of our hospitals currently and looks at patients' vital signs, laboratory studies, and tries to identify sepsis at an earlier time point than a physician might be able to. It is pretty unobtrusive. You get a small alert on the trackboard or in the patient's chart, and it says, do you think this patient could be septic? And it lists the data that it used to come to that conclusion. You could say, I want to ignore the patient's tachycardia. This is from AFib with RVR. Or I want to ignore this creatinine because a month ago their creatinine was similarly elevated. And it will recalculate. But so far, I found it really useful. It does pick up on some things that I might miss at an early time point. And at least with their internal testing and study that was published in Nature, it's really efficacious. Here are a handful of other AI-driven applications. So there's some automated coding and charging. I am very lucky. I don't have to do my own billing, but I know a lot of my colleagues, especially those in private practice, do. These automated coding tools can work with your ambient listening AI scribe technology to also spit out ICD-10 codes into your chart automatically. Automatic note summarization. I have found this very helpful. It can be difficult to look through a patient's 30-day hospitalization and pick out these were the critical decision points. This is what affected the patient's care. And if this saves me 5 or 10 minutes of chart review, that is huge. A lot of the EMRs are also experimenting with augmented response technology. So if a patient will send you a message through the EMR asking this or that clinical question, this helps you very quickly generate a response. It might give 2 or 3 different options about things that your office staff or your nurse or even you could say back to the patient that would be somewhat based in evidence-based medicine and might help overcome a little bit of writer's block too. So how can you get involved? When I first started this role, I thought about what was the most time-consuming or what annoyed me the most about my day-to-day job. I would always forget to order those troponins, or what is a form that was highly audited that we needed to get right every single time, like EMTALA, for example. the EMTALA form whenever we're transferring patients between hospitals, something that CMS always looks for. So how do we make sure that a patient physically cannot be transferred, they can't be moved out of the EMR unless that EMTALA form is 100% complete? Once you've identified those pain points, ask, if you're at a larger institution, ask your informaticist. A lot of institutions have somebody that's dedicated at least part-time to maintaining the electronic medical record and the informatics infrastructure. There are also a lot of physician support specialists, so the people that do the training whenever you first enter a hospital or in your EMR. Now, if you're in private practice, you might not have access to those resources, which is okay, because these are really common issues, and a lot of state and specialty societies are creating an AI task force or an informatics task force to kind of collate a lot of these best practices and distribute them to your members. There's also the online forums for your electronic medical record. So I mentioned the Epic Galaxy and user forum that has program packages that you can, with very little work, take and move directly into your implementation of the electronic medical record. And those are free of charge. Anybody can publish to that and anybody can download from that. So with that, I would like to open it up to questions. What would you guys like to know about informatics, AI, whatever you want to discuss is fair game.
Great. Thank you so much, Dr. Rudawsky. Would you just mind closing the slides just so we get everyone? Yeah, that'd be great. Excellent. And so opening up to the floor, it'd be great if you just use the hand raising tool on Zoom and I can call on you, or alternatively, feel free to direct message me on Zoom and I can ask your question. So I will start off with the question I had. So UNC is in the process of implementing a bridge, and I think one question that's come up is just for trainees, and so there's been some discussion that PGY1s and PGY2s wouldn't have access to the AI scribe, just so that they would have more experience with summarizing and writing notes. And I was curious, at Cleveland, has there been discussion about the role of AI and trainees and how to make sure that, on one hand, people are pressed for time and stressed, and it's important to have efficient tools. On the other hand, do you worry too about just people just taking excessive shortcuts, particularly in formative parts of their training?
Yes, so this is something we have discussed at length, and actually, I think it might have come out either yesterday or today. We signed a contract with one of higher enterprise, and that's going to be open to all clinicians, so both attendings, residents, and our PA and NP colleagues. And that was done purposely for, I guess, two reasons. One, it's how we're all going to be practicing in the future. So my son, who's in kindergarten, has an iPad at school, and we really try to limit screen time as much as we can. We don't want him just sitting on Netflix or playing video games the entire time. But I recognize I can't take his iPad away, because that's how he's going to be learning in the future. This is what his career is going to be like. So we thought that it would be worthwhile to give everyone access to those tools, because that's what we're going to be using. Two, the feedback on them was so overwhelmingly positive. So we piloted 6 different scribe tools before we settled on the one vendor, and we did pre and post surveys, and we did measures of physician burnout during these different pilots to see which ones made clinicians happier. And overwhelmingly, even for the products that weren't the leaders in the pack, there was less physician burnout. People were more satisfied with their jobs if they spent less time charting. So we didn't want to hold that back when it was so beneficial.
Great, appreciate that. And then Dr. Singh?
Hi. I just had a question about HIPAA related concerns with the AI scribes and if there's been discussion surrounding that.
Oh, yeah, a ton of discussion. So there are a few different standards that companies can use to validate their tools for HIPAA compliance. There are lots of white papers on these different websites for Abridge or Ambience or DAX Copilot about how specifically they've been validated. But that's also where these third-party consortiums like Kai or Train come in, because they've done some of that validation as well. So we don't just have to take the company's word for it. We can look to some of these external kind of non-biased organizations. A lot of them do, well, not a lot, all of them save the data to some extent, but the retention policies are pretty different. The one that we ended up going with stores the data for 2 weeks before the recording is expunged. And that's in case you have to go back and there was an error with the recording, or you have an issue that you need tech support from the company. They at least have the ability to go back and troubleshoot that.
Then I guess on a similar note too, just curious what discussions you've had about malpractice. So for instance, you were talking about using the AI tool for extracting information from the chart, and then if it hallucinates and that impacts patient care and results in a harm, is it then you're just personally assuming the liability, or do you have to describe, actually, if it's going to be something crucial decision making, actually pull up the actual note just to verify that this actually happened in the patient's history?
That is a really good point, because you're completely right. These algorithms can invent things. How the large language models work is they try to guess the next most appropriate 2 or 3 or 4 or 5 or 6 words based on their training set. And we like to think that it gets it right. I use it for a lot of low risk stuff like writing emails, or maybe summarizing information that I give it, but generating something de novo is much higher risk. So I think right now, at least when we're pushing out the AI scribe, for example, we're saying trust but verify. But in terms of who would assume the risk for that when it's the AI model that makes a mistake, we don't have a good answer for. Something that the American Medical Association looked into over the past year with 2 different board reports, and we haven't come to any good conclusions yet. I'm lucky that I have a ton of institute-supported malpractice insurance.
I might just piggy onto that to say that I've also heard there's the possibility of malpractice regarding the lack of use of AI to augment your care as well, particularly when it comes to like radiology or something.
Yeah, that's a good point. I mean, it's kind of like using ultrasound for central lines. When I started doing central lines, we were not doing ultrasound. It was only based on anatomy. And now if there was an adverse outcome, and I didn't use ultrasound, I would definitely be at fault because it isn't the standard of care anymore. So this, like I said, this is the Wild West. It's really unregulated at the moment. We don't really know how this is going to shake out a couple of years from now.
Hans had sent a question earlier, and I think you started to address this tangentially, but the question was asking about how we can leverage health informatics to address healthcare disparities. And I mean, I think certainly protocolizing things is one way so that you're basing your decisions on more evidence-based pathways consistently. But I was curious about other ways that you've seen that both health informatics and AI could be used to address disparities.
So social determinants of health in general, we've kind of now starting to recognize that these are so important in how care is provided across an entire population. I know that Epic at least is implementing some tools to bring those identified social determinants of health to the forefront of the physician chart. I'm not sure if you guys on your storyboard have the little icons of the cloud and the smoking and housing and things like that. But those are things that we weren't necessarily thinking about a while ago that we're now considering because the EMR is making that information easier to access. I'm not aware of any AI tools that are taking advantage of that other than just things that are displayed in the medical record, but probably more to come in that over the next couple of years.
Then, and I was curious too, is if Cleveland has also been using this for pain management, because I know that's an area where there's been huge disparities, often along racial lines, of who may receive narcotics and who not, and then also just cases where I mean, both ways where you have patients who are being inappropriately denied pain medications when they have like very clear pathologies like sickle cell disease, where I think they should be given the benefit of the doubt. And then on the other side, cases where there just may be some unsafe prescribing.
Sure. The only pain management, I guess, experience that I have in the ED is with the sickle cell population with inner city Cleveland. And we've addressed that through protocolization. So we've worked with the other hospital systems in the area to come up with a very standardized pain medication regimen that is fair to patients and also discourages doctor shopping, because patients know that no matter where they go, the care that they receive, even across different institutions, is going to be pretty similar. We've also made that information a lot more accessible within the EMR. So records are now much more accessible, even between different EMRs than they used to be 5 years ago. So it's very easy to see if a patient is established with neighboring hospital XYZ. This is who their hematologist oncologist is. This was their most recent reticulocyte count. And therefore, today's visit is a departure and I really should contact this other doc. But again, that's my little teeny window into pain management. I am fortunate that I don't have to do a ton.
Yeah. And then I see one, and again, I'm happy, please just want to encourage others to ask questions as well. But I mean, I could see that, I mean, I think one potential drawback to AI is that you could see, like, particularly for-profit actors who would use this as a way to just find ways to maximize billing in terms of just trying to add on. I know we're moving away generally from a fee-for-service model, but they could try to find ways to do additional diagnostic tests to try to increase the complexity of patients. And do you see, just from a health economic standpoint, some dangers where just AI might be just used more for maximizing profit, more so than for maximizing just patient care?
Oh, absolutely. I could for sure see that happening. Right now, our focus has been on recognizing the work that we do, and we probably are all providing much more care than we are able to bill for, or than we do bill for. So some of the tools that we built into our medical decision making, just with highlighting important conversations or independently interpreting images, have been focused on recognizing events that we know happen in the EMR and then asking clinicians to document that stuff. But you're right, I could very easily see some of these decision support tools saying, hey, why don't you order that chest x-ray? Might help might help support medical complexity.
Just to kind of jump in on that, one of the things I worry about is that it seems like this is something that could potentially help with burnout in terms of documentation, and that's all great. But then also, I noticed in some of the slides that it's really expanding your ability to treat more patients. And so does it then become a driver to do more, like see more patients, get more patients in, which then also helps contribute to burnout? It's not just documentation that's burning us out, right?
Oh, you're absolutely right. I'm insulated somewhat from that in the ED because I have to see everybody that shows up. But that was one of the questions that was on our AI scribe surveys is, do you feel like this tool would allow you to see one more patient during your workday? Do you feel like it's freed up enough time that you could do that? And I think as an institution, you would have to create some very clear policies that would say you're going to be capped at this no matter what. These are the expectations for the number of patients that you're going to see, even with these tools, because I mean, at some point, something has to give. And we can't just keep expecting our docs to do more and more and more.
I was also curious too at the AMA, has there been any questions about how this might change the scope of practice landscape, where if you gave these, that there might be groups that are just trying to seek to hire non-physician employees and say, okay, well, we don't need their expertise as much if we're just giving our APPs AI tools.
Oh, yeah. So far, the messaging has been, we are still the captains of the ship. We are responsible for verifying the information that augmented intelligence supplies and acting on that appropriately. We shouldn't trust it blindly. I do appreciate open evidence citing its sources and allowing you to directly link to those journal articles, do that review yourself. And I think any tools that we implement in the future would have to include something like that. We can't just trust it blindly because these tools hallucinate. How do you know you're getting correct information unless you know enough to be able to verify that yourself? Thankfully, aside from open evidence, nothing is really doing any medical decision making for us at this point. Just suggesting sepsis or suggesting this is what should be in your note, and you still have to write the note.
Do we have any final questions or comments?
So I have a comment that's not related to this. I appreciate this. Has been a very nice presentation of an important topic, but are we going to have time in this meeting to talk about what's going on the national scene as far as health and healthcare? I may be alone in this, but I'm quite upset with the fact that the AMA seems to have had nothing to say about some of the craziness coming out of the administration, nor has the North Carolina Medical Society. I'm talking about the muzzling of the CDC. I'm talking about RFK Jr.'s nomination. I'm talking about vilifying Anthony Fauci and on and on. Why has organized medicine been so silent about this stuff, giving the impression to many, including legislators like our own Tom Tillis, that we're fine with this stuff? Is this something we can discuss as a society?
Dr. Arzen, thank you for those comments. That's something that I think is very close concern to so many of us who actually believe in evidence-based medicine and equity and fairness. We didn't really budget this types of virtual meetings for those opportunities and thought that those discussions would be better suited for when we have our in-person meetings, which is going to be in April as well. It is not that we don't think that that's important. This just wasn't really the focus of how we structured these virtual meetings.
Would you be interested though, and maybe we could even try I know April's still a while off, but would that be of interest? We could even try to organize some kind of, whether it's virtually or in person, just have a separate discussion.
Well, I personally would be in favor of that. I mean, I believe we're to serve the public as part of our mission. I believe the public looks to us to protect their interests and for us to be silent in the face of a lot of actions that I think many of us think are totally nuts is a disservice. And I think it's unprofessional, frankly. And I think waiting till April to talk about it, given the pace at which change is happening, and frankly, to my mind, destruction is happening, is not a good idea.
I would say one good opportunity that we have as DOCMS and CMS members is there's actually that legislative meeting that's coming up on the 28th. That was just I just got an email about it, and I'm trying to figure out a way to get there because there are going to be some state legislators there. I know it's on the state level, not so much the national level. but I agree, and actually have been having the same thoughts this week, like how to bring this up without dismissing our speaker, who was marvelous, and it's a great topic. But it does feel like sometimes we need to just, it may be that we need to have an additional meeting, or at least for the board to get together and have some sort of statement. I do think we need to say something. I agree with you, Dr. Eisenson.
So, Dr. Robinson, there's also, I think, to what Dr. Godwin was alluding, there's the social on the 28th of February, and then actually the following day is the state advocacy summit, which I think that, as somebody who's particularly engaged in advocacy, I would hope to be able to see you there. Just in deference to our speaker, perhaps you and I can chat uh, later this week about your thoughts, and I can bring them back to the board for discussion and think about how we can approach that. Would that be okay with you?
Sure, that'll be fine. Thank you.
I'll email you my cell phone number so we can find some time to chat.
Sounds good. Thank you.
Of course. Um, any other questions, comments for our speaker? Okay, well, Dr. Rudawsky, really thank you for joining us. I do have a little bit of housekeeping I do have to do. That is to announce our CME code. Um, we still do it with a text, and so the phone number to text I'm putting in the chat, and the code is NEGDUQ, also going in the chat. So for those of you who wish to claim CME for this, that's the number to the text, and then the code to send. We'll leave the screen going for a couple minutes, just so that, because you can only claim it, at least for this initial one, during the session. But otherwise, thank you so much, Rudy. We really appreciate you being here for our inaugural one of doing a virtual meeting, and just for sharing your insights on a topic that is, feels so much like a black box to so many people. And it's just so incredible to see that the work that you're doing in this space and making it just so much more tangible for so many of us.
Well, I really appreciate the opportunity to talk to you guys, and thanks again for inviting me.
Yeah, thank
And
you.
if you guys think of any questions, Hans has my email address. I'll type it into the chat as well, but feel free to email. I'd be happy to discuss things more.
I'm ready for you to start trying to convince the VA to use it, because we're all burning out.
The VA is actually using some image analysis tools, but I have very limited insight into what else they're doing. But I know that they are
We
doing.
keep getting little hints that it may happen, but the main problem is it's the same reason that we can't. I use VR for pain in our. I'm in an interdisciplinary pain clinic, and I'll put people in virtual reality, but I can't use like a Meta Quest headset because it gathers data. And so I have to use these like clunky, old, terrible headsets. So I'm ready for you to come lobby the VA.
Thank you very much. That was an excellent presentation tonight.
Thank you.
Thank you, Rudy. And I think with that, I hope everybody's had time to submit their CME, in which case, I wish you all a very good night, and we will see you in April.